Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from GlaxoSmithKline.
Hello, and welcome to this program entitled Unlocking the Path to Optimal Severe Asthma Care, Strategies for Success. I'm Dr. Nick Hanani. I'm Professor of Medicine and Director of the Airway Clinical Research Center at Baylor College of Medicine in Houston, Texas. It is my pleasure to moderate this session today, and I am very glad to be joined by two esteemed colleagues, Dr. Sujani Kakugmanu. She's a clinical associate professor, allergy and immunology at the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin, and Dr. Jay Lieberman, professor, Department of Pediatric, Division of Pediatric Pulmonary Allergy and Immunology at the University of Tennessee Health Science Center in Memphis, Tennessee. Sujani and Jay, welcome, and I look forward to a fruitful discussion. So why are we here today? Well, obviously, asthma is a worldwide problem. Does not spare any age group, does not spare any race. It is common in all countries, whether it's developed or developing countries. But throughout the world, we know about 250 million children and adolescents and adults are affected with asthma. In the United States, about 25 million asthmatics have been identified, 5 million children and 20 million adults. So it's a very prevalent disease. However, one of the major problems with asthma, it's the fact that 50% of patients with asthma remain uncontrolled despite adequate approach to this disease. Despite the fact that we have guidelines and strategies, we continue to see patients who come to us with uncontrolled disease. Out of those, about 5 to 10% of patients have what we call severe asthma. Now, one has to be very careful defining asthma control as well as differentiating poorly controlled asthma or uncontrolled asthma from severe asthma. Severe asthma is a smaller group of this bigger group of uncontrolled disease. Those are the patients who continue to exacerbate despite adequate therapy, despite being on high dose ICS or long-acting bronchodilator, or those who need oral corticosteroid to control their disease. So our understanding of asthma over the years has changed. I remember, and I've been in practice for 30 years now, our approach to asthma at that time, that it is a one-phase disease. That has changed. We know now that asthma has multiple phases. Indeed, one size does not fit all with asthma. And as I will see in our discussions today, we're going to talk about clinical scenarios that can help us as clinicians identify who's the right patient for the right treatment. We know that there are multiple clinical phenotypes for asthma, different presentation. There's a late onset asthma, early onset asthma, allergic, non-allergic. And not only that, but now with the era of biomarkers, we can actually identify what we call endotypes of the disease. What are the mechanisms of the disease? All this because we are in the era of precision medicine. We cannot accept the fact that all asthmatics should be treated the same way, that all asthmatics have the same disease, that all asthmatics will respond the same to one treatment or the other. So that is one of our challenge today and one of the big aims in discussing the topic. First, I want to thank also my fellow speakers for taking the time to teach us today. And I'm going to ask Dr. Jay Lieberman to lead us with the first case, was a pediatric case. And we're going to build up our discussion about the challenges, but more so the opportunities for approaching asthma, especially poorly controlled asthma in the era of precision medicine. Jay, can you talk to us about the case that you brought?
Yeah, thanks a lot, Nick. So we'll start a discussion with a case of a adolescent, so a 14-year-old patient who's had asthma and wheeze since about the age of 4 years. They have a history of hospitalization. That was years ago at age 6, but still continues to get oral steroid bursts around 2 to 3 times per year for flares. And that patient will present to the urgent care, emergency department, primary care provider with wheezing and get a steroid burst. So currently, the patient's prescribed an inhaled corticosteroid and a long-acting beta agonist combo. So budesonide for Motorol at 80 micrograms and 4.5 micrograms, 2 puffs twice a day. They're also prescribed a leukotriene antagonist, montelukast, at 5 milligrams each night. So despite that treatment, this patient, like we said, is getting frequent oral steroid bursts, but also reports some impairment in the form of difficulty keeping up with peers in soccer practice due to shortness of breath or cough. Patient also reports using the rescue inhaler 4 to 5 times per week and getting nocturnal cough when their asthma acts up, which is a couple times per month. In seeing this patient, they've had a workup on in the visit in the clinic on that day. They had an asthma control test score of 14, which would suggest not optimally controlled asthma. They have a spirometry, which shows mild obstruction, and a FeNO, a fractional exhaled nitric oxide, of 45 parts per billion. Skin testing showed positive tests to tree pollen, dust mite, and cockroach, so evidence of allergic sensitization. A CBC showed an eosinophil count of 485 cells per microliter and a total IgE count of 250. So based on this, it'll be a nice jumping point to discuss kind of what's the next step in this patient's management.
Yeah, thanks, Jay. I don't see kids. I'm an adult pulmonologist, but I'm puzzled how uncontrolled this disease is, and whether it's an adult or is it pediatric, despite the fact that we have adequate therapies. And I'm also intrigued that, assessment of control is a major thing. And now that we have both an adult and a pediatric allergist on this panel, uh, how do you assess asthma control? I see that you had an ACT test. Is that something that uniformly you use?
Yeah, so we find the control questionnaires, whether you use the ACQ, the ACT. The ACT has childhood forms. These are pretty easy one-page assessments that can be given to the patient, upon check-in by the person checking the patient and getting their vitals, handing them the form so that they can be filling it out before the provider even gets in the room. It's an easy way to objectify some of the questions that you're going to be asking them anyway.
And Sujani, in your adult practice, is this similar?
Yes, we use most commonly in my practice the ACT, and there are other questionnaires as well. They're validated at the summation of the scores, but I do find that the individual questions can sometimes offer an important cue for how to query further how their asthma is. So, for example, in this last case, Jay had mentioned that they had a significant impairment domain and they had significant activity limitations. And one of the questions from often of these questionnaires is your activity limited? And I think that can offer a very introduction to a very rich discussion into more quantifying that limitation a little bit more.
I, like yourself, I use ACT in a clinic. Unfortunately, ACT maybe doesn't specifically ask about exacerbations, which are again important. And there are some questionnaires. AirQ, for example, has an exacerbation type of arm. But I think that's another important issue for our colleagues who are watching this. That yes, assessing asthma control important. Assessing exacerbation or risk is very important. And I think there's a uniform agreement that these two things are important. And then now there's another added one that can tell you who's at risk by looking at certain biomarkers, like blood EOs and even FeNO. If in a specialty care we measure exhaled nitric oxide. That's great. So, Jujani, GINA, the international body, has put in sort of a strategy to approach uncontrolled asthma. Can you walk us through some of the major highlights on what they recommend?
Yes, thank you, Nicholas. So, a couple things with uncontrolled asthma. It is important to differentiate the elements that might be playing a role into that uncontrolled asthma, whether it's difficulty taking the medicine or accessing the medicine. Certainly, elements of non-adherence can play a big role in a patient's level of control. In addition, considering the comorbidities that might be playing a role in whether somebody is having increased asthma symptoms. For example, if they're having increased upper airway symptoms, those symptoms need to be controlled in order to fully get control over their asthma as well. And then importantly, triggers and risk factors are a huge component of how we manage asthma and how we manage uncontrolled asthma. So if a patient is smoking, having access to smoking cessation programs, environmental exposures, and keeping in mind that some of these triggers may be very different for each of your patients. And certainly exposure to air pollutants may be very different in one patient population versus the other. And then, like you were mentioning, Dr. Hanania, the increased role of biomarkers like blood eosinophils and FeNO can be an important component on how we diagnose endotype and phenotype for these patients. So as we consider uncontrolled asthma, I think putting all of this together into a full picture for that individual patient in front of you and figuring out coping strategies depending on what factor seems to be playing a role for that patient in your clinic.
Thank you so much. And obviously, Jay, with managing asthma, whether it's children or adults, it's not just about drugs, and medications are important. So non-pharmacologic approaches, being an allergist, I know you do that all the day, all the time, assess allergies and sensitization. But if we talk about pharmacotherapy, since we want to focus on that in this short segment, pharmacotherapies, there are quite a few, and we've done good advancement. Can you actually walk us through the strategy that Gina suggests? I know it's a bit different between countries, and they have track 1 and track 2 now. But maybe give us a highlight on when it comes to medications, treating asthmatics who are uncontrolled, how do we do it?
Yeah, so when I'm talking to my trainees, for example, when we're going through GINA steps, I do tell them this isn't concrete. It gives us guidance on what to do, and you don't have to follow every step. But the main things that have kind of changed recently with GINA, as well as in the U.S. guidelines that have been published, is that we're obviously going away from using albuterol as the only controller and instituting a controller that has both an inhaled steroid component as well as in the GINA guidelines, a long-acting beta agonist and specifically formoterol. So using an ICS formoterol combination as the reliever at all times. So it's a big transition for a lot of people managing asthma to say, wow, I'm not going to have albuterol anymore. I'm just going to have an ICS formoterol combination as my rescue inhaler. That's probably one of the biggest changes that GINA has brought about, or guidelines have brought about in the last few years. After that, when you're starting to talk about beyond just as needed medications and going with controllers, it is still using inhaled steroids as our backbone, as our cornerstone, but really having on the LABA component, the long-acting beta agonist in the form of formoterol at a very early step after you've gone past just as needed medications. In our patient, going back to our patient, they were on inhaled corticosteroid with budesonide 80 micrograms, 2 puffs twice a day, in addition to the long-acting beta agonist. So essentially at step 4 of the GINA guidelines, a medium dose inhaled corticosteroid formoterol. So our patient in that sense is now at medium dose inhaled steroid, long-acting beta agonist, and was also on a leukotriene antagonist. So stepping up at that point is really where it gets kind of interesting, because you have different options. In modern times, one of the most common options we add on is biologics, and we'll talk about that. But I'll add on, in addition to what Johnny said, and before you make that step up, I think it's really important to make sure, and not only adherence that we talked about, but proper use of the device. So you have to understand, in the GINA in Europe, they have the dry powdered inhaler ICS combo. In the US, obviously, you guys know we don't have that. So if they're using a meter dose inhaler for budesonide formoterol or mometasone formoterol, for example, I always make sure they have their spacer and educate them on how to use that if they're not using a dry powdered inhaler.
Thank you so much. I wanted to dwell on this escalation, and I know there both data in children and adults, escalating the dose of inhaled steroid. It's not a magic wand, as you hope you all agree. In fact, there's some data in kids, even if you quadruple the dose of ICS, it's not like a straight line. There is a plateau to the effect. So, and of course, there is always increased risk of side effects. But in adults too, there are some data to show that doubling the dose of ICS does not always do it. In fact, in adults, we also now add long-acting antimuscarinic agents on top of long-acting beta agonists. I know that's something that is not very common in kids. Jay, do you use llamas in your practice?
Yeah, it's harder to use llamas because, or at least in the U.S., the tiotropium is approved down to years of age in a certain form, but not in the single inhalers. So you don't have a triple inhaler, one device to give them under 18. So it's a little harder. We do use it sometimes, but I hate adding on three different inhalers. It's very hard for some families to do that sometimes.
Right. So again, our efforts have to be to do this checklist and go over the reasons why these patients remain uncontrolled. And we're going to talk about adherence. That's a major one. Use of inhaler devices, triggers, comorbidity is very important, and of course trying to escalate therapy. And what Gina suggests that in those patients, once we do that checklist, if they continue to have symptoms, is to do some kind of phenotyping. And the suggestion is to do certain biomarker measurement like blood EOs. And if you have the luxury of measuring pheno in specialty practice, pheno, to identify what we call type 2 high asthma versus non-type 2 asthma. These are the two major phenotypes that we have based on biomarker, because we know now that if we're going to escalate further, and we're going to talk about biologics in a few minutes, we have to know that most biologics approved in the United States are approved for patients with type 2 high asthma. So I think biomarker measurements should not just be only restricted to our specialty in allergy, immunology, or pulmonary, but I think primary care docs can do certain measurements like blood EOs. If they're high, they suggest a patient may have type 2 asthma. If the patient is allergic, like this young lady, she has early onset allergic asthma, IgE was high, then that's also type 2 asthma as well. And so I think that that's the way of thinking. And you do your homework, you escalate, you make sure they're using their inhalers, and then obviously now we have really good benefits in a way in those patients who fail to respond. That's where biologics and the landscape for biologic has expanded quite a bit in the last few years. We have now 6 approved biologics for asthma, for severe asthma. Jay, you want to just start the discussion about, what are the biologics that we have, and briefly, obviously, you don't have too much time. And, I know you're a pediatrician, but why don't you lead the discussion on what do we have out there?
Yeah, so as allergists, obviously, we use biologics all the time because they're approved not just for asthma, but multiple atopic conditions, which is nice because then you can ideally treat multiple conditions with one medication, and it really helps out the patient. So right now in the U.S., we have omalizumab, which was approved about 30 years ago now for asthma. That targets IgE and is approved for 6 years of age and above. It's subcutaneous and dosed every 2 or 4 weeks. For asthma, the dosing is dependent on the patient's total IgE as well as their weight. We have mepolizumab that's targeted at interleukin 5, which is the main cytokine that drives eosinophil production and chemotaxis. It's approved for greater than 6 years of age. It's subcutaneous and dosed every 4 weeks. We have reslizumab, also targeted right at IL-5. It's different though in that it's approved over 18, but it's IV, so it can be dosed by weight, which may be a benefit in some patients. It's dosed every 4 weeks. Benralizumab is targeted also to IL-5, but it's a little bit different because it targets the IL-5 receptor on the eosinophil rather than IL-5 itself. It's approved in the United States for greater than 6 years of age for asthma, also sub-Q. You start out at Q4-week dosing, but then you quickly go to Q8-week dosing so you can spread out that frequency, which might be helpful for some patients. Dupilumab is targeted at the IL-4 receptor, so it blocks the activity of IL-4 and IL-13, which are cytokines that play a role in multiple atopic conditions. Approved 6 years of age and older for asthma, although it does go younger for other conditions. It is subcutaneous and dosed every 2 or 4 weeks, depending on age for asthma. And the last one we have is tezepelumab, which it targets TSLP or thymic stromal lymphopoietin. It's a kind of key regulator for downstream allergic cascade. It's approved for greater than 12 years of age in the United States. It's also subcutaneous and dosed every 4 weeks.
Well, thank you, Jay. So there's six of them, and obviously for the practicing allergist and pulmonologist, we always sometimes scratch our head to decide which one is the best for our patient. Obviously, the comorbidities, we're talking about the choice of biologics, and that's something that we would like to discuss more. But before that, we can maybe start discussing the second case that Sujani brought to us. And I think we will revisit how do we choose biologics, whether it's children or adult, in the era that we have six of them and maybe more to come. Sujani, why don't you share with us your case that you brought to our attention here?
Sure. So this case illustrates some key points of an adult patient with severe asthma. This is a 45-year-old female. She presents with a history of chronic sinusitis as well as nasal polyposis. She does have a high burden of disease, with having about 2 to 3 exacerbations requiring oral steroid bursts per year. She's currently taking what we call high dose budesonide formoterol, puffs twice a day with a spacer, and is using a more traditional approach in that she's using albuterol for her rescue medication. For her sinusitis and nasal polyp disease, she's currently using high-dose fluticasone nasal spray, 2 sprays in each nostril twice a day, as well as sinus rinses. When we see her in clinic, she does show some evidence of poorly controlled asthma with an ACT score of 16. Her FeNO is high at 56. She does not show significant evidence of atopy, so her IgE is relatively low. She has no positive skin test results. And when we did her spirometry, she does show significant evidence of obstruction. And significantly, she does show some signs of bronchodilator reversibility, which is consistent with a diagnosis of asthma. And her whole picture, in addition to her spirometry, is really consistent with a diagnosis of severe asthma.
Great. Well, these two cases have some similarity, obviously, the different age group, but one is early onset allergic, the other one is late onset, but also non-allergic, but both have type 2 asthma based on their FeNO levels. And we don't know what the blood EOs in this second case is, but I assume they probably are high as well. The lung function is an issue, and I'd like to have that as the part of the discussion. Does lung function affect the choice of biologic? And then there are certain other reasons why we can pick one biologic versus the other. And maybe we can start with Sujani, your take on it as an adult allergist, and what are things you consider in choosing which biologic to pick first?
Yeah, I think in this patient in particular, one of the things that we really look at is her comorbidities. And because there's some recent data that shows that certain comorbidities might predict or might be associated with increased response to biologics, and certain biologics in particular. I think in this patient, her chronic sinusitis and nasal polyposis does significantly affect the choice of biologics. In the slide that Jay was referring to earlier, we know that there's 3 biologics that's been shown to have some effect on nasal polyposis, and that's omalizumab, mepolizumab, and dupilumab. In this patient, she doesn't show significant signs of atopic disease. Her IgE is low. She doesn't have significant skin test positivities. And her evidence of chronic sinusitis and nasal polyposis has been associated with a greater response to dupilumab in these patients. And that, depending on formulary and access to that medication, might be one of the first ones in this particular patient, given her asthma phenotype and endotype, that I would consider, along with her high FeNO, which is also associated with perhaps with a greater response to dupilumab. So I think putting together those biomarkers and how they present in the patient can be really helpful.
Good, great. Jay, your take on it in pediatrics, is there anything else you want to add that will determine the choice of biologic, knowing the fact that in some situations more than one may work, but which one to pick?
Yeah, for me, I would agree with everything Sujani said. I would add in for obviously age. Some are approved down to 6, and some are 12, and some are 18. So that's a huge part of it for the pediatric side. The other thing that we consider is frequency of dosing in kids, right? Kids don't like needles, so if we can have a less frequent dosing, sometimes that is enough to kind of say, well, I'm going to choose that one over another one. So I love this slide kind of that puts it all together, says we're going to take all of this and consider it and not just always select one or the other.
Yeah, I like both of you. I look at the holistic picture. Of course, we're going to talk about how do we put the patient in the picture, where the patient's sometimes preference is important. Of course, the cost, the payers can also dictate which one to choose. Lung function, and I'm an adult pulmonologist, as I mentioned, and definitely I look at lung function. It's not only that low lung function predict for future exacerbation, but it can be associated with poor outcomes and other than exacerbation, but symptoms and exercise intolerance. And there is indeed, when you look at clinical trials, there are studies that show that one biologic may have a better effect on lung function improvement than others. So that's something that I like to look at, not only in in choosing the biologic, but also as a follow-up to see if lung function improves. Uh, there are certain barriers. Unfortunately, we have to address this as clinicians. It's not always a green field in front of us when it comes to choosing a treatment. And whether it's an inhaled therapy or it's biologic, there are certain concerns for these patients. So, Johnny, I know you're interested in adherence, which is a major issue. You want to tell us how do you assess adherence and what are some major issues with adherence to therapy?
Yeah, thank you. I think a big starting point for assessing a patient's inability to take a medicine or perhaps their level of non-adherence is to realize that there are different kinds of barriers that might be associated with that observation. So there's individual level barriers, both on the side of the patient as well as the clinician in front of them. And then also societal or economic barriers that may be greater than that interaction in clinic itself. And so, looking at the patient and asking them some questions on, in a non-judgmental way, is it difficult for you to get your medicine? Why perhaps are you not taking your medicine? Are there times where you're able to take your medicine and times that you're not able to take your medicine? And I think looking for patterns of use, looking for reasons for why the patient is not able to use their medicines in the way that you would like is really, really important. And it can be an important introduction to a conversation on, well, how do I actually tackle this issue of not being able to take medicines? Do I provide the patient with some ability to introduce this into their routine? If they're having difficulty remembering it, perhaps putting it next to their toothbrush can be really helpful in having them take it on a day-to-day basis. If they're not sure when to take their rescue medicines or how to implement single maintenance and reliever therapy, giving them an asthma action plan and teaching them how to use it. So not just giving it to them, but teaching them how to use it can be very helpful. And, oftentimes we have patients who either don't believe that medicine is going to work for them or are concerned about side effects. And I think if you uncover that that's a reason, giving them some access to perhaps a community health worker who they might identify with a little bit better might be a way to tackle those issues of believing that medicine may be able to help them, or talking to a family member, or perhaps talking about it longitudinally. Sometimes we don't make behavior change at that first visit.
Yeah, that's great. And in my patient population, I see lots of elderly asthma, and the polypharmacy is a major issue. I think some of the adherence issue is non-intentional. They forget they have multiple medications to worry about. Cost is a big issue. They can't afford all the medications, so they have to prioritize the rescue inhalers over their controllers. And certainly when it comes to biologic, payments and reimbursement is a major issue. Jay, in the pediatric population, how often do you communicate these issues with I've had teenagers now. My kids are grown up, but I know teenagers are rebellious. They don't want to take their medication. They don't want to be labeled with a chronic disease. How do you deal with this? How often do you communicate with their caregivers? And
The answer to how do I deal with it is not well. It's so hard. But the reality is, it's every visit is education and discussion, and it's always bringing the patient into the discussion. I think is really important. Like Sujani said, it's not necessarily that they don't want to take it or whatever it is. Just understanding what that is, and then having the discussion and getting any kind of buy-in from the patient. Teenagers are very hard. But whatever you can do from a buy-in point of view, I think is really important.
I want to discuss a very important issue when it comes to biologic is the shared decision making. It's something that I think we sometimes forget that it's a two-way highway, and because this is a sort of a chronic treatment, we believe biologics once the patient responds, that right now there are really no good rules when to stop. That's another very big unmet need. When to switch, or can we stop? So in general, it's a long-term treatment, and it's a costly treatment. So I think a shared decision making is something that needs to be done. I actually do that before I prescribe the biology. I sit down with the patient, give them some brochures. We have a website that we developed with American College of Allergy Immunology, as well as with CHEST, the ACCP, that they can link to it and read about which biologic is available. We can help them out with telling them, these are the possible biologics that may work. They come back and talk to us, and then they make a shared decision. Obviously, the payer may play a big role eventually, knowing which formulary they have and what coverage. But it's very important, and I think I hope you all agree with me that this is a very important exercise to do when it comes to just like we do it with other disease states. Now, what about specialists? All three of us are specialists, so we end up seeing the tip of the iceberg, those sick ones. Is there any strategy on who should we advocate our primary care colleagues to refer to us? Maybe Jay, we can start with you, and then Sujani, and um, who are the ones you want to be seeing in your clinic?
For me, like what I tell trainees, for example, residents who are going to become internists, family medicine doctors, or pediatrics, I say, referral whenever you feel is appropriate. We are here for you as the specialist. If you feel comfortable managing up to a certain point, great. If you don't feel comfortable, great. I think specialists have resources that primary care providers may not have, to give more time or more in-depth education, etc. But what my simple rule is, if you refer whenever you don't feel comfortable managing that anymore, we are here to help you as the specialist.
And Sujani, your take on it?
Yes, I agree with that as well. And I think especially when in addition to that, especially when patients establish a pattern of uncontrolled asthma or having a lot of exacerbations, and you start to think about, those higher, more intensive levels of pharmacotherapy, I think we all would agree we want to see those patients in our clinic if a biologic is something that you're thinking about, if they have a lot of comorbidities, and especially if they're having a lot of exacerbations, we definitely want them to touch base with a specialist. But I agree with Jay, there is a lot of intensive education and follow up that has to happen for a lot of our patients with asthma. And, we certainly are here to help our primary care colleagues with that component of things as well.
No, that's beautifully said, both of you. And I would add, I usually advocate like anyone who is needing oral steroids more than twice a year in the past year. If you need some testing that you cannot do in your clinic, even spirometry. Some of my primary care colleagues don't have access to spirometry. Anyone who is hospitalized for asthma, hospitalization for asthma is a very bad thing. It's a red flag that this patient is high risk. These patients deserve to be seen by a specialist. And certainly, if you want to escalate therapy beyond current treatment, or you think there is a comorbidity that you can't tackle, these are some points where you may elect to refer to a specialist and for us to work together. And we were talking about communication, and it's communication not just with the patient and family, but also specialists to primary care communications is very, very important. It's a partnership to manage asthma. It actually takes a village to manage asthma. Even within our clinic, if it was in the respiratory care, the nurses, the pharmacy, the asthma educator uh, can't do it. Physicians alone cannot do it. So it really takes a team effort. So I want to try to summarize. This has been a very enlightening discussion, and I want to thank my colleagues for this. So I want to just remind everyone that asthma is here to stay. It's an old disease, but now we know that it is an impactful disease. And unfortunately, many patients out there continue to have uncontrolled disease. The good news is majority of these patients can have controlled asthma if you do a simple sort of checklist and check their adherence, use of inhaler device, triggers, comorbidities. However, in some patients, they deserve to be assessed further. And these are the patients with severe disease, where we have now the luxury of doing phenotyping and endotyping, measuring biomarker, and deciding if they are fit for certain biologics. And as you heard, we have several available now. There are several ways to assess and pick the right biologic. And certainly this science is evolving right now. But again, putting the patient and his caregiver in the discussion is very important. Again, I want to thank you, Sujani and Jay, for taking the time and enlightening us with this great discussion. And again, I want to thank you on behalf of my colleagues. And I want to also thank you all who participated in this activity. I would like to ask you to continue on to answer the questions that follow and complete the evaluation.